Altered level of consciousness is one of the more common things we will see in EMS. More so because there are so many different causes of altered levels of consciousness. This chapter, chapter 22, is going to cover the specifics about diabetics and diabetic emergencies, but it's also going to cover some of the more common causes of altered mental status. Not all of the slides are going to have voiceover. Some of them are meant to be read, and some of them are meant to take time to reflect on the topics that were already covered. There may also be information to be used in discussion boards to follow. So this is chapter 22, diabetic emergencies and altered mental status. Here you can refer back to the pathophysiology part of your anatomy and physiology. The pathophysiology of our normal brain function requires constant supply of oxygen, sugar or glucose, and water. It needs to have the ability to move electricity, which moves quicker through water. It also needs to have that moisture, so we cannot have things overheat. We need to have that oxygen supply, so we cannot become hypoxic. We need to have that glucose or the energy to feed the muscles and the movement, so we cannot become hypoglycemic or hyperglycemic. The brain tissue requires oxygen, sugar, and water. Any deficiencies in the oxygen, sugar, or water can result in an altered level of consciousness. This could be due to trauma, infection, toxins, poisons, brain disease or problems, other body systems that are affecting the use or flow of the three: water, sugar, or oxygen, or it could be deficiencies in our sleep-wake cycle. When covering the assessment of an altered mental patient, safety is going to be number one. We need to make sure we are safe as well as the patient is safe. Practice makes perfect. We allow sufficient time to practice your skills of talking to somebody that may not be cooperative with their answers. They may be confused, they may be altered, they may be unable to communicate. Patients with an altered level of consciousness are unreliable and can be very dangerous. We are not sure how they're going to respond or react. The sweetest old lady may become very angry and can actually be so strong that even her bones break because she is unaware of what she is doing. People may be acting very strangely. Some people can become very suicidal or homicidal in these situations. Regardless of how they are acting, all of your patients need to be assessed for airway, breathing, circulations problems. Always consider that there is a different medical reason or life threat that is causing their altered level of consciousness. Rapidly identify altered level of consciousness caused by the hypoxia or the airway breathing. Also rapidly identify anything that could be caused by a trauma and a lack of blood supply. Altered level of consciousness doesn't mean that they are unresponsive or unconscious. It just means that they are not completely with it. They can be conscious, walking around, alert, looking at you, but they can be confused. They could have abnormal gait. They could have abnormal speech. So different levels of consciousness is not just in AVPU, but AVPU is going to be the quickest for you to categorize whether they're alert, respond to pain, respond to verbal stimulus, or they're completely unresponsive. From there, you can actually start to divulge their level above that. So this is where your GCS may come into play. If you have a patient that has had some sort of trauma, we get their AVPU, but then we can get more into their level of GCS. One of the vital signs that you need to monitor is not just blood pressure, heart rate, respirations, temps, skin, pupils, anything like that. It's also their level of consciousness. You may see a drop in their mentation before you see any drop in the other values. Just a little bit of confusion can indicate that the person's becoming more shocky or hypoxic. We need to make sure that the baseline that we're seeing is their true baseline. Somebody with dementia or Alzheimer's may have this level of consciousness that we would believe is altered, but this is their new normal. Or somebody that has developmental delays, this is their normal. So we cannot just base what our presentation that we see of the level of consciousness as something that is acute and needs to be treated. You're going to look over different medications, see what medical history this person has that may contribute to their level of consciousness. Look for medical bracelets, look for tattoos, look for necklaces, maybe a wallet card. There's many different things that you can find that can indicate whether they have some sort of medical history that can contribute to this altered level of consciousness. How might an assessment of a mental status in a child differ from that of an adult? Children may not be able to express their thoughts, their confusion in the same manner as an adult, especially when you come to small children, infants and toddlers. They're not able to express whether they're confused. Going off of how their cry is or how they're consoled may be how you determine their level of consciousness. Go over the presentation on Glasgow Coma Scale. It provides a more precise measurement of a patient's responses. It's more in-depth than just the AVPU. And you should always have a beginning GCS and an ending GCS if you do not have multiples in the middle. Because a very subtle change from someone being conscious, alert, and oriented to person, place, and event, and then all of a sudden they're confused. They're still A on the AVPU, but they have changed mentation ever so slightly on the GCS, which indicates to us that something is more severely wrong. So AVPU is more just down and dirty, very quick assessment to gather them into either they're alert or they're not alert. The GCS scale breaks it down into eye movement, which is going to be very similar to your AVPU. They either look up at you, they look when you speak to them, they look when you give them a painful response, or they don't look at all. They are unresponsive. The next third of the GCS is going to be our verbal responses. Conscious, alert, oriented, know who they are, know what's going on, know what day of the year or day of the week it is, the year it is, who the president is. That's going to be somebody that is completely oriented. Then you drop it down to a little confused. Maybe they know who the president is, but they're not sure of the time of day. They're not sure of even the year that it is. Somebody that you ask them what time it is and they look at their watch. Yes, they might not have known what the time was, but they are oriented enough to look at their watch. So that indicates that they do know how to find that answer. Instead of being confused, they may be just making some very bizarre statements. Like they're saying words, but none of the words are making a whole lot of sense. They're saying sentences that do not make sense. That's worse than somebody that is confused. So you can see how things start to deteriorate. Below that is going to be somebody that's not saying words. They're just saying random noises, more incomprehensible moans and groans. That is even worse than somebody that's talking about the big fluffy bunny in the spruce tree. You ask them how they're feeling today, and they tell you that the walrus outside stole the peanut butter sandwich. That doesn't make sense. But it's still better than somebody that just mumbles and grumbles. And then below that is no response at all. And you'll notice a pattern with your GCS. There's going to be a no response at all. And that is going to be worth 1 point. So your eyes, they don't move at all. When you talk to them, pinch them, poke them, prod them, yell at them, that's a 1. they don't respond. They don't make any noise. They're not confused, but they're also not making any noise at all. No mumbly, grumbly, no moans in pain. That's a 1. And the last section of the GCS is their motor response. The best you can get is going to be a 6. 6 means I tell you to squeeze your hand and you do it. I tell you to open your eyes and stick out your tongue and you do it. That is going to be following commands when asked upon. That is the best you can do for motor. From there, we start to get into unable to follow the commands. When I pinch your arm and you slap my hand away, that's better than when I pinch your arm and you kind of just shift your body slowly away. So you're actually withdrawing or focusing on that level of stimulus or pain. So which one's better? Recognizing that there's irritation and reaching for it, or recognizing their irritation but they are unable to reach for it? They kind of just pull. So that would be your 5 and then your 4 respectively. Below that is going to be your posturing. Posturing is bad news. Posturing is going to be some sort of hemorrhaging of the brain. The brain is swelling. It's better to be towards the core. So if I rub your sternum and everything kind of folds in towards the core, I think of it as like your last ditch effort, everything goes sunken into the core. The body wants to save the core. So the body starts to curl towards the core, or decorticate posturing. When it gets worse from there, the body kind of gives up all hope and kind of just brushes things off. Everything goes off to the side. So hands go down to the side, everything kind of curls outwards, and that's your discerabit posturing. And then if they don't move at all, that's worth a 1, unresponsive. Glucose is a form of sugar, and it is the body's main source of energy. Cells require glucose to remain active and to create energy. It takes energy to expel energy. Sugar and carbohydrates are converted into glucose, and then glucose is absorbed into the bloodstream. Glucose is a large molecule. It cannot pass into the cell. That's why we need insulin. So glucose is this, if you think of it like a large person that cannot fit through like a small door. You almost need a pill to make you smaller, kind of like in Alice in Wonderland, and that would be your insulin. You need to make it to where the large glucose can get into the cell. The pancreas secretes insulin when the blood glucose exceeds 90 milligrams per deciliter. So we munch, yum, yum, yum. We eat a bunch of food. It's got some carbohydrates. It gets converted into glucose. Our pancreas recognizes this and starts to secrete insulin. This insulin binds and allows the cells to go through and into the cells, from the bloodstream and into the cells. So here is a diagram. Your pancreas creates the insulin. It has the blood sugar outside the cells. The insulin grabs the glucose and allows it to form and go into the cell. Patients who are diabetic either do not produce insulin at all or do not produce enough insulin. Sometimes they have an autoimmune disorder to where their body kind of attacks their ability to create insulin. This is where you're going to have people that are basically born as diabetics. They do not have the ability to make the insulin because their body has actually destroyed that ability to create or use insulin. It basically becomes resistant to that insulin that is produced. This here is another way to describe how insulin uses or is used in the body. It's kind of like a key that unlocks a door. Once the door is open, the glucose can enter. So we need insulin to be able to transfer that glucose molecule. Khan Academy has an excellent set of videos that covers diabetes. It covers the different types of diabetes, your type 1, which is commonly known as the childhood diabetes, even though it's actually more common in young adults to be diagnosed, as well as type 2 diabetics and your gestational diabetics. So if you look up Khan Academy, you should be able to find some great animations on diabetes. In type 1, the pancreas does not produce insulin correctly, or it does not function correctly to create the insulin. If there is too little insulin to transfer the glucose into the cells, the blood glucose just kind of floats around in the blood. This is where we're going to get a significantly high blood sugar level. So they'll have tons of sugar, but it's just sitting in the bloodstream and not going into the cells. There's no key to unlock the doors. So the sugar is just going to kind of float around in the blood, making it thicker, making it more like syrup or molasses. So these type 1, they need to have a synthetic insulin that is given to them to open those doors or to make the glucose able to go into the cells and out of the bloodstream. In type 2, this is where the body is unable to use the insulin properly, or it's not making enough. So it's not that the pancreas doesn't make it at all. So type 1, the pancreas is unable to create its own insulin. In type 2, more often it is related to obesity. They have eaten so much glucose in their life or carbohydrates and fats that has kind of overworked the pancreas to where it's not making it as effectively, or it's not getting enough insulin due to the large amounts of sugar in the diet. Many times, type 2 diabetics can be controlled through diet or oral anti-diabetic medications, and even sometimes insulin if it gets to that point. They can become insulin-dependent diabetics after some time if it is not controlled. So you start seeing some anti-diabetic medications. Metformin is a really common one that is given to people that they consider themselves pre-diabetic, but in fact, they are diabetic, they're just pre-insulin dependent. Diabetic emergencies are really common in AMS. It could be from too much insulin or too much sugar, too little sugar, over-exercising or overuse of the energy. They could be vomiting. If you can't eat, or when you do eat, you vomit it up, you're unable to absorb any of the nutrients and carbohydrates. Maybe there's an increased metabolic rate. So you'll see these in kids with a large growth spurt. They'll be fine with their sugar levels and their insulin levels, and then they'll hit a growth spurt, and those levels that were prescribed to them before are no longer able to keep up with their metabolic rate. When sugar is reduced, the brain and the body cells start to starve. So even if there is a ton of sugar floating around in the rest of the body, it is not being converted into usable energy because it is not being moved into the cells, and the cells will starve. Hypoglycemia, if left untreated, can lead to death. It can also lead to permanent brain damage. The onset is going to be rapid. Hypoglycemia is going to be rapid. Abnormal behavior, they may appear to be drunk. They may be appearing to be on drugs or medications. They're going to be pale and sweaty because nutrients are not going to the right cells. They're not getting enough energy. They're becoming tachycardic. These kind of symptoms are showing you some sort of trait that's similar to shock. So they look shocky. Their cells are not getting the energy they need. So it is a type of hypoglycemic shock. They may have rapid breathing. This may, in turn, reach the levels where they start to have seizures. Their body's not getting the nutrients it needs, and cells start to misfire. So they'll end up with twitching and shaking and seizure-like activity. So the key to this is the rapid onset and altered level of consciousness and almost shocky appearance. In hypoglycemia, as long as they still have an intact ability to swallow and enough mentation to be able to protect their airway, the most common thing that we're going to use is oral glucose. Oral glucose can come in a couple different sizes, between 24 grams or 12 grams or 18 grams. Depends on what your service carries and what you're allowed to give. The biggest contraindication to oral glucose is the inability to protect the airway. Even if you're unable to determine if it is a hyper or hypoglycemic patient, if it is suspected that they are having a diabetic emergency and their blood sugar is way over 1,000 and you give them oral glucose, it may raise it a little bit and they're still going to be sick. If their blood sugar is down to 20 and you give them oral glucose, it could save their life. So do not hesitate. If you have all the signs and symptoms, everything's pointing to a diabetic emergency. They have a history of diabetes. They're acting altered. There's been some inability to take medications or eat properly or anything above. Giving oral glucose to somebody with an outrageously high blood sugar is not going to kill them because they're already in need of significant amounts of fluid and insulin and everything to be titrated. They have to go to the hospital. But if they are low blood sugar and you give them oral glucose, you will save their life. If they do not have the ability to protect their airway, you may have to go through another means. How oral glucose works is it is absorbed through the mucous membranes. When you swallow something, it starts to get broken down by stomach acid, then it gets absorbed through the small intestine. It can take 15-20 minutes for this to take effect. When substances are absorbed through mucous membranes in our cheeks and gums, it's absorbed into the bloodstream rather quickly. If a person has hypoglycemia, so not enough sugar, putting it in their cheeks, if they can protect their airway, is going to have it absorbed rather quickly. Then they can swallow it. So convincing them to kind of swish it around and then swallow it. So it starts to absorb quickly. They swallow it, get it out of their airway. They can breathe a little bit, kind of hang out, then you can give them some more. If they cannot protect their airway, one of our other mucous membranes is actually at the other end of the spectrum. So going in through the rectum, there is mucous membranes there. You want to make sure that you don't puncture anything. It can be rather messy. It's going to be messy. It's going to be sticky. So be prepared of what you're going to be getting into. Make sure you've got the appropriate PPE. But this is a matter of life and death. This person will die if they do not get sugar to the rest of their body and to their brain. Hyperglycemia is high blood sugar. It is caused by not enough insulin or inability to use the insulin. Maybe they did not give themselves insulin the last 2 days. They've eaten a lot of extra food. Maybe they have been on a really strict exercise regimen and they hurt themselves, so they took the regular insulin that they've been using, but instead of going for their 3-mile jog that they do every day, they sat at home and they ate a Subway sandwich. So it increased their carbohydrates and they didn't need to, they had more stores and they needed energy. So they ended up having way too much sugar floating around as opposed to their insulin levels. The difference between hypoglycemia and hyperglycemia develops over days or weeks because it'll be high and then it will continue to slowly get higher. Their body's going to try to compensate for it. So your blood sugar starts to become thick like molasses. When you want something sticky, you go and you wash your hands. So you put more water on it. So people that have a really sticky blood vessels, they're going to want to try to dilute it down. They're going to drink a lot more water. They're going to try to just make that sugar kind of diluted out. So you're going to see these people drinking a lot. They're going to drink, drink, drink. When you drink a lot, you pee a lot. So they're going to be drinking and peeing and drinking and peeing. They may want to eat more because remember, they have a ton of sugar in their blood, but it's not actually going into their cells. So their cells still feel a little, their cells still feel a little hungry. They're not getting the insulin to be able to move that sugar into the cells. So they're still hungry. So they're wanting to eat, which is going to slowly increase more of their sugar in their blood. So they're eating and drinking and peeing and eating and drinking and peeing. And with all this eating and drinking, they're still not able to dilute out that sugar that's in their blood. So they're going to feel dehydrated. They're going to feel hot and dehydrated and keep eating and drinking, and they're just not getting the right energy, which might make them feel nauseous. So these are not symptoms that you saw with the hypoglycemia. Remember, with hypoglycemia, we saw almost shocky states where they're pale, they're almost in a stupor, they have high heart rates, they have high respiratory rates, almost shocky. Here, they're eating, they're drinking, they're peeing, they're feeling sick. It's been several days, it's been a week. Slowly, their cells start to starve because the glucose is stuck in the bloodstream and unable to move from the blood and into the cells. When these cells starve, they start to burn fats and proteins instead of using the sugar. And when you burn fat, you actually start to create like a ketosis. Healthy ketosis is one thing, but diabetic ketoacidosis is not a good thing. So once you become more acidic in your diabetic ketoacidosis, you can start to become incredibly shocky. Our body is meant to be in a certain homeostasis of pH. We don't want to be too acidic and we don't want to be too alkalytic. Both ends of the spectrum burns. Lye is incredibly alkalytic and can burn through skin tissues. Our stomach acid breaks down all sorts of things that we eat. We don't need to have our body, and our body would not be able to handle being too acidic or basic. Sides of DKA is going to be altered level of consciousness. Their blood sugar is going to be through the roof. It's going to be something that has taken time, that eating, drinking, peeing. They're going to try to fix, their body's going to try to fix this acidosis by rapid breathing. Some people can smell a sickeningly sweet smell on the people's breath and kind of describe it as an acetone. I am one of the people that do not smell. I do not smell it at all. I can see somebody in DKA, but I do not smell that super sweet, almost like they are sweating sugar. Regardless of your hypo or hyperglycemia, you need to make sure that you do a full patient assessment, starting with scene safety. Ensure your safety, your partner's safety, and the patient's safety. If they're having seizure-like activity, we need to protect them from any trauma or harm. We need to get as much information as we can from the scene. We look for needles, insulin needles. We look for medications. We look for insulin meds in the fridge. We look for glucometers in the kitchen, needles, those type things, lancets. We look for any type of clues that can tell us that this person is diabetic. You look for bracelets and watches. You ask neighbors, friends, family members. Try to get an idea of, oh, Timmy's been drinking a lot of water for the last 3 days and mom couldn't wake him up this morning. That can identify that maybe he's having a hyperglycemic episode because he's unconscious, he's been eating and drinking outrageous amounts of food and water lately, peeing a lot. It could be an indication that we need to check his blood sugar and see how high it is. We need to assess their ability to swallow. Can they protect their own airway if we were to give them sugar by mouth? This patient assessment goes along with all the other patient assessments that we've done. We're always going to check airway, breathing, circulation. In the back of our mind, we're going to be focusing and gearing towards a diabetic emergency, but we always need to start with the immediate life threats. Is there an airway problem? Are they breathing? Is it adequate? Do they have a pulse? Are they having adequate circulation? Do they need to have compressions done? Do they need to be treated for shock? Are they losing blood volume? These are the type of things we have to ask regardless of what our patient's history is. Glucose monitors help us get a quick assessment of what their blood sugar is. Not all services allow EMTs to be able to use a glucometer. We should not use the patient's glucometer. We don't know if it's been calibrated. We don't know how accurate it's going to be. And every glucometer has its own set of calibration instructions. Some of them have a plus or minus feature of 100 milligrams per deciliter, which means that if you get a reading of 20, it could be off, like give or take up to like 100, because it's not an accurate assessment. It is only taking capillary blood and giving us a reading. What it needs to do is these people were going to get a more accurate reading when they go to the hospital and get actual blood work done. But it can give us a very good assessment rather quickly in less than 5 minutes. But we need to treat the patient and not the monitor. If our patient's signs and symptoms show us that they have a history of diabetes, they're acting abnormal, we can give them sugar in hopes that it will fix. Because having a little bit of sugar is not going to kill somebody that has a blood sugar of over 1,000. But withholding sugar because you don't have a glucometer could end up having somebody die in your ambulance instead. So go with your local protocols on whether you're allowed to use a glucometer or not, but use your patient assessment skills. Get an idea of what's going on with your patient. Do you have an idea what's wrong with them? Do you have the tools necessary to treat them? Here you see the glucometer. You've got test strips. Test strips are located here. The glucometer itself, it'll give you a reading, so 75 milligrams per deciliter. Alcohol wipes and lancets. Different meters will have different tools in their kit. In most services, most protocols, less than 60 with a symptomatic diabetic indicates hypoglycemia. Anything less than 50 causes alterations in their mental status. Greater than 140 indicates hyperglycemia, and then greater than 300 for prolonged periods of time can lead to dehydration. Think of it like molasses running through your veins instead of blood and water. If I am a diabetic and I sit at 200 all the time, every day, all day, if I go down to 80, that could make me symptomatic. That can make me altered, even though it's not in our values of something that is our typical altered. This is why you shouldn't treat numbers or treat the monitor, treat the patient. If your patient is always elevated in their blood sugar levels, being down to what normal levels would be for the average non-diabetic could actually put them into an altered level of consciousness. For your patient care report, you need to make sure that you document a history of diabetes, their level of consciousness, what made you determine whether they are having a diabetic emergency, and you need to describe their airway. Do they have the ability to protect their airway and to swallow? Once you give the sugar, you are going to reassess, and you have to document what your reassessment is. Are they starting to come to? Are they answering questions appropriately? Have their vital signs more normalized? If you are able to get a glucometer, what was their blood sugar before? And then what is their blood sugar after? Make sure that you document all of this inside your patient care report. Here's a quick guideline on comparing hypo and hyper. So hypo is going to come on suddenly. Remember, it's going to be acute. Low blood sugar, they're not getting enough blood sugar, maybe too much insulin, and they're going to look shocky. They're going to be cold, clammy skin. They may not have any specific type of odor or smell because there's no sugar permeating off of their body. Hyperglycemia has slow onset, eating and drinking, eating and drinking, eating and drinking. Their skin is going to be warm, red, dry. Think of them as being sticky and dehydrated. They may also be sweating off of some of that sugar, trying to get rid of it as much as they can. Other causes of altered level of consciousness could be seizures, could be stroke, could be drug or toxins, poisons. Many different things causes altered levels of consciousness. Seizures result from a disorganized firing of neurons in the brain. A seizure is not a disease in itself, but rather a sign of an underlying defect, injury, or disease. On your exams, you're going to need to know the difference between a partial seizure and a generalized seizure. Your book is going to cover the differences, and you can get more information from Khan Academy on animations on the difference between a generalized seizure or a partial seizure. The generalized one is more often called like the tonic-clonic. So tonic and clonic are actually two different features. One of them is the spasmic moving, and one of them is like the clenching. So a patient wildly thrashing around inside the movies is actually not going to be as accurate. It's actually more rhythmic thrashing, and it could be described as wild. The whole body is going to be involved with the generalized, so think general as being whole, and it is going to be like a rapid squeezing of muscles or tensing of muscles, and then this spasmodic like relaxation twitching. It's not going to be flailing arms from side to side and hopping up and down and those type things. That is not what a seizure is going to look like. This is the difference in your tonic phase and your clonic phase. So that body tightening, the actual contraction of muscle is that tonic phase. The body is rigid. The clonic phase is that spasming or the jerking motion. If you think about it, your diaphragm is a muscle. So if your diaphragm is constantly squeezing, it is not allowing you to breathe. So these people have a significant airway breathing compromise. We may not be able to breathe for them, but putting some blow-by oxygen by them may help. The post-ictal phase. This is when the convulsions stop, and this phase lasts throughout their consciousness. They need to regain consciousness. When they wake up, they may be drowsy. They may feel like they just ran a marathon because their entire body just spent however long their seizure was, basically going through every muscle tightening and squeezing. They may become violent. They are unaware of what was going on. Some seizures, before they have the seizure, have what some describe as an aura. They may smell something, they hear something. Often it's described as a smelling of burnt popcorn. And then they go into their seizure, and then they have their post-ictal phase. There are many different causes of seizures. Someone can have a disease that causes seizures, and they may be prescribed anti-seizure medication. Commonly in children and infants, it's a rapid increase in temperature, and it's not a huge increase. So they don't go from like 98.6 to 107. It's going from 98.6 to 100 very rapidly in a matter of seconds that causes their seizure. Other causes of seizure can be hypoxia, not getting enough oxygen, or a stroke, not getting enough oxygen to certain areas of the brain, and then that neuro tissue starts to misfire. It could be from sugar. It could be from a traumatic brain injury. Epilepsy is essentially just a term to describe multiple seizures of an unknown cause. They don't know what else causes the seizure. They diagnose somebody with having epilepsy or seizure disorder. They may be born with it, or it may develop later in their life. Maybe an injury, maybe some sort of illness or surgery caused it. Many times these people can live normal lives without seizures if they take their medication appropriately. What to document for your patient assessment is getting a history of description of what the seizure was. Was it tonic-clonic? Was it a full body seizure? Was it just partial? Was it just like the right side of their body? Was it just an inability to control certain body parts? Getting an idea of how much of the seizure was involved. Were they just staring off into space and not moving at all? Was there an aura? Ask somebody that was with them to say that sometimes when people have seizures, they know what's going to happen and they can lay themselves down. There's actually animals out there that can detect when a seizure is going to happen. Did the dog sit right before little Timmy started having a seizure? Was there loss of bladder or bowel control? This can kind of confirm the difference between like seizures and other activities like syncope. Syncope is not to be confused with a seizure because it is a fainting. It could be more cardiovascular than neural in nature. How long did the seizure last, and are they still post-ictal, or have they gained any consciousness? We need to know what they did after the seizure as well as during and before the seizure. All of this stuff needs to be documented. We need to be able to say on our paperwork what we found out about the seizure, if it's still in seizure, and to describe it. Because somebody that may have a history of like focal seizures where they just kind of stare off and then all of a sudden their seizures have transformed into generalized tonic-clonic seizures, something else has changed within their body. Something else is going on in their brain that is not their normal, because their seizure history has become part of their normal. We need to make sure that they're safe. Was there any trauma involved during the seizure? We need to make sure that their airway, breathing, circulation is not compromised. Loosening any clothing that might be around the neck, so ties or buttoned up shirts, those things can be loosened while they're having a seizure, so any air that does get to come in doesn't get blocked by tight-fitting clothing. Putting padded areas around cribs or beds for patients that have a potential to have seizures is going to protect them from additional trauma. These are the considerations you want to take when dealing with somebody that has a seizure disorder or you're being called to fix the seizure. Sometimes patients that have a diagnosis of epilepsy will try to refuse care once they come out of their seizure. This is their normal. They don't want to go to the hospital. They have a history of seizures. You need to document your attempts to get them to transport. You also need to ensure that they do sign a refusal, and it needs to be an informed refusal, telling them that they can go back into seizure at any moment and that they need to have people there with them at all times. Somebody that is in seizure for too long, their brain actually can start to cook. They go through all of their sugar stores and they can end up dying. They overheat, they stop breathing. So many different factors come into play when somebody's having a seizure. So informing them of the hazards of not transporting before they sign the refusal is required. You need to allow them to make that decision and document it thoroughly on your paperwork. Another cause of altered level of consciousness is stroke. Stroke could be from a block, it could be from a bleed. There's a couple different things that cause stroke. Stroke, if you think about it, is very similar to like a myocardial infarction in your heart attack. This is kind of like a brain attack. If you have a clot, whether it's an air embolism or a blood clot that's going through, some other sort of like plaque that has blocked an artery, that is an ischemic stroke. Basically, no blood and oxygen can get past that block, and the obstruction creates an area of the brain that starts to starve and die off. Hemorrhagic stroke is from a bleed. It could be a ruptured vessel. It could be from an aneurysm that has burst. Not only is the blood not going where it needs to go because of the bleed, but sometimes that blood building up can put pressure on the outside of the brain and can kill more tissue. So it's like the leaky balloon leaks fluid everywhere, and it takes up all that excess space outside the brain underneath the skull, and it just keeps pushing and building and pushing and building on top of the brain, and it kills that brain tissue later. A TIA is kind of like a mini stroke, and it should be taken very seriously. It's little teeny clots that end up being resolved after a short period of time. There's no permanent brain damage, but there are periods of hypoxia. They are at risk of a full-blown stroke and should be evaluated as soon as possible, so try to convince them to go to the hospital. The Cincinnati Prehospital Stroke Scale is one of the most common and easily used stroke assessments that you can do. If you remember FAST, which is going to be face, arms, speech, and time, you will be able to assess the Cincinnati Stroke Scale on your patients and do your stroke assessment. So face, you're looking for a grimace, uneven face of, like uneven shape of their face. So one side drooping more than the other, unable to smile. You're also going to look at their arm drift. You're going to see in the next slides about how to do an arm drift. You just want their eyes closed and you want their palms up. If you just do like a Frankenstein walk with their palms down, one of the symptoms of a stroke is the inability to keep your palms up, and it will flip over to where the palm is facing down. So if you start them facing down, you will not see that symptom. So eyes closed, palms up, arms outstretched. If their eyes are open and they see their hands start to fall, they may try to force it back up. If their eyes are closed and their hand falls, they don't know. They don't realize that it has fallen. That's why we want to have their eyes closed when their arms are up. So face, have them smile, have them stick their tongue out, have them make a certain kind of face. Try to distinguish whether both eyebrows go up, both cheekbones move when they smile, when they frown. When they smile with their teeth, do you see both sides of their lips going up? You want to look for changes bilaterally. Once you start seeing the unilateral of one side change, uni being one, lateral being side, once you start seeing a unilateral change, you can be more suspicious of a stroke. S is going to be speech. You're going to want them to repeat a saying. I like to say, "It's always sunny in Philadelphia," because I like that TV show. The book will describe saying you can't teach an old dog new tricks. Some people may find that offensive if they assume that you're talking about them being old and not learning things. So come up with a very common saying that people can repeat. Nothing convoluted and bizarre. You want it to be a sentence that they can repeat that is possibly commonly known. A lot of people know the phrase, "You can't teach an old dog new tricks." And so if they aren't able to form those words or they say inappropriate words, it's a good way to determine whether their brain is getting the signals to their mouth and if they're able to interpret. So there's different cranial nerves that are involved in the ability to make speech and form words. The T in time is kind of a twofold. So T being time being you need to be fast, you need to react quickly. Time is of the essence. We need to get them to a hospital to where they can stop the bleed or move the clot out of the way to start feeding that part of the brain again. Time is also, when was the last time they were seen normal? Because we have to determine how long this has been going on for. Some medications, you need to be within a 6-hour window or an 8-hour window before those medications are no longer going to be effective. Time is muscle, time is brain. So the longer they're having a stroke, the longer that their brain is unable to be fed, the more permanent damage there is going to be. So if grandma went to sleep at 9 and the next person that saw her was at 6 o'clock in the morning and she had stroke-like symptoms, we have to assume that her stroke started at 9 o'clock. Even if she didn't start having symptoms until 3 o'clock in the morning, there is no way for us to determine that. So when was the last time that grandma was seen normal before she started having stroke-like symptoms? The next slides are going to be covering all of these Cincinnati Stroke Scale questions. As stated before, syncope could be merely fainting, but it could be an indication that there is something else going on with the body. More than likely, it is some sort of cardiovascular type compromise. Something in the body is not being fed appropriately or working appropriately, and the person ends up having a fainting spell. It could be that their heart has almost had like a hiccup, that there was a little blip or a time when there was no movement of blood vessels or anything getting to the brain and they went unconscious. It could be that they stood up too quickly and their body was unable to compensate for that sudden rush when they stood up. I don't know how many of you have ever been sitting for a long time and then stood up too quickly and got kind of lightheaded. Imagine just passing out from doing that. Our body compensates pretty quickly, but as we age, we might not be able to compensate so quickly. Some people will have a syncopal episode in the bathroom. They're bearing down and they're pushing, trying to get some constipated poop out. And they bear down so hard that they end up putting so much pressure on their vagus nerve, and the vagus nerve controls a lot of functions in our body, and they end up passing out. It decreases their heart rate so much that they end up going unconscious. So even though syncope could be benign, fainting could be a benign symptom, it could be an indication that there is something more sinister happening in their body. Often seizures and syncope point to a larger problem. Although it may be part of the patient's chief complaint, always look for a different problem that could be causing that. Problems such as cardiac dysrhythmia, stroke, sepsis, they can all cause seizures and syncope and could be far worse than the actual symptom of fainting. Also get a description of what they mean by dizziness. Were they spinning? Was the room spinning? Was there double vision? Was it blurry? Were there lights? Did you have some sort of warning? Did you feel a symptom beforehand or like an aura? When did it start and how long did it last? What position were you in? Were you standing? Were you sitting? Were you laying down? Being intoxicated and laying down, maybe the whole room spins as opposed to standing up quickly. Have you had any similar episodes in the past that you can attribute it to? Something else, part of your medical history that has very similar symptoms? Inflammation, there are many things that cause altered level of consciousness. A lot of services still use an acronym called AEIOU TIPS, which could be alcohol, epilepsy, infection or insulin, oxygenation, uremia, toxins or trauma, the other I for like infection or insulin, psychosis, stroke or seizure. There's so many different things that can be used in the AEIOU tips. When you have somebody that's unconscious or unresponsive, confused, start going through all the different possibilities that it could be. Go with the ones that you can treat the easiest. The easiest to treat is going to be hypo or hyperglycemia. Also check their temperature. Maybe they're too cold or they're too hot. Those are things that we can easily fix. We can also give them oxygen. So check their oxygenation level. See if they need to be put on a non-rebreather mask. Things that are going to be harder to fix are going to be your strokes, your severe bleeds. Those type things, they're going to need to have surgical intervention. Maybe that's a cardiovascular problem and they're going to go see a cardiologist and get a blockage cleared. Maybe they have a seizure disorder. Maybe they have a genetic malformation. These are things that we can't really see or treat, but we can start to rule them in by ruling other things out. We've ruled out that there is no alcohol in their system or recreational drugs. They don't have a history of diabetes. They don't have a history of seizures in the past. They don't have stroke-like symptoms. They're just confused. Is there other things that can be causing this confusion? Is there a recent trauma, possible bleed in their brain? Maybe they were out skiing and hit their head on a tree. So these are different things that we can rule in and rule out. The whole subject of this chapter is to try to figure out what causes a person's level of consciousness to be altered and different things that we can do to fix it. The biggest ones are going to be the ones that we can treat at the pre-hospital setting. Other ones, we may have to transport them to the hospital and have a doctor or a specialist care for them instead. In those cases, we still need to treat our airway, breathing, circulation, and treat for life threats, making sure that we've treated their blood sugar, their airway problems, their respiratory problems, and fixing any cause of hypoxia, and making sure that anything that is that their pulse is working, and any blood that may be leaving the body has been plugged up or replenished with a blood supply. Hopefully you guys have some takeaway from this chapter, and go ahead and read the rest of the chapter review, and good luck on your exam. Cyanotic skin demonstrates the need for immediate airway management and high concentration of oxygen. Once the airway has been secured, the primary assessment must be completed. Rule out any life-threatening causes of the seizure, like hypoxia, hypoglycemia, and stroke.